Hello friends of Dental XP. I'm Dr. Alberto Fernandez from Ibiza, Spain. And I'd like to start by saying thank you to Dental XP by their achievements in continuing education, particularly Dr. Mauricio Lama for the invitation to participate with you today. And the topic of my lecture and the purpose of my lecture is to look for an alternative of autogenous bone grafting on cases for a patient. And in this sense, I'd like to tell you that the subject, it's a little confusing sometimes, and it has some aspects that even now are not completely considered in the literature. And I know that with these I will step on dangerous fields and I might offend somebody with my concepts, but I will try to explain them in depth, and I would like to show you the rationale and the scientific basis that move my ideas on what I do. In all my lectures I like to organize the material, and you will see how I organize them. And I would like to show you the points, the principal points or objectives that I will talk about. I'd like to start by saying that you can see on the drawings that teeth and implants behave differently upon the situations of the surrounding tissues. And this is due to the naturality of the tissues. And as I mentioned, the lectures I like to organize them. And I would like to start today with an introduction. Then I will go to basic concepts and what is then my philosophy of treatment. Finally, I will show you some clinical cases, do a little resume, and then have a small time for questions. All these points will be on the lower part of the screen, and you will see a little blue line that will go from left to right as we advance on the lecture. As an introduction, I have a nice picture of the island of Ibiza. This is where I'm from. It is worldwide known for its parties and good time. Unfortunately, very little known for their professionals in oral health. I hope this changes in the future, and maybe Ibiza will be a place for continuing education as well. Starting with the basics, I would like to mention a paper by Dr. Schroeder, and I think it's my responsibility to show this. Dr. Schroeder did a nice, very great paper in which he does a synopsis of the periodontal tissues. And what I see is outstanding is that after so many years in lectures and so many lectures I've seen, we have to go back to these papers to explain the clinical basics, the natural science, the basic science. And with these, we can understand that all this effort that we're doing in understanding the clinical issues, we must understand the basic, the natural science, the basic science is underneath it. So we can understand the mucosal cover will cover, as the word says, some of the tissues of the gingiva. And we have two big points that change direction. One is the mucogingival line that will divide a mobile tissue with an attached tissue. And this type of tissue attached will continue all the way to the free gingival margin, and then it will change on a trip going inwards, and will have a different type of epithelium that is non-keratinized. Once we have access to this epithelium, we will be in a cavity, in a real cavity, and we will see some tissues, descamative tissues that are colonizing the area. If we continue inwards, we will come to a very amazing structure that is the junctional epithelium. And I would like to type of a story tell you the aspects that we see over here. It is interesting for me to see that the final part of this junctional epithelium will come down to a one cell contact with the tooth surface. And this cell contact, if we go deep in the microscope, we will have a bunch of hemidesmosomes that attach to the tooth surface. And this attachment will be mediated by a lamina lucida and have a union with the cells that is known as the hemidesmosomes. And going more apically, we will see the connective tissue inserting to the tooth surface. And then what we'll have is a concentration of connective tissue fibers that attach to the tooth surface. And this is a very nice and sophisticated system of connection between the soft tissue and the hard tissue. And if we see it on a drawing, we will have some different directions of the fibers, as well as the blood vessels and all the other components that behave and populate these spaces. And this is something that is fundamental in the behavior of the tissues during the wound healing when we do a procedure. To finish this, we must understand that this union between the bone and the tooth surface will be different when we don't have the tooth surface. So we can start showing the pictures of this paper by Araujo and Linde, and we can see on the picture on the left how the laminar bone is united to the tooth through the bundle bone. So when we have a loss of the tooth, most probably we will lose as well the bundle bone. Now, this event of the loosening of the loss of the bundle bone will take place through a certain time. It is not something that will occur one day to another. So this is a concept we must have in mind when we do an extraction. Because when we have an extraction, we will have certain steps on or phases in which the healing will take place. And this was very well described by Araujo and Linde. Now, when we have a loss of a tooth, we will as well have a loss of the alveolus structure. And it will all start by the first part of the resorptive process, that is when we lose the bundle bone. And then we will have a second phase, a secondary phase, in which we will have a loss of the structure, but we don't know how much of the structure we will lose. Now, on the 2005 papers, we did not know exactly how much of a resorption we will have on the secondary phase. We will have the secondary phase of destruction in animals. Now in humans, the hard tissue, we will have a horizontal dimension reduction as well as a vertical reduction. So when we have an extraction, we will have a destructive process on a horizontal and vertical dimension. Now, this will be something to really consider when we have an extraction, because when we lose a tooth or when we have to extract a tooth, we will have to plan how to regain or regenerate that loss of bone that will happen, especially on the horizontal matter. And I think it is very important how much of a volume of bone we lose and how much of the structure of bone. And this is why, since I was trained as a dentist, I have always tried all my cases finish excellent. And I was very secure, very conscient in my mind that I need to augment the quantity and the quality of the bone in order to be able to regenerate the tissues and leave them ready for a future implant placement or crown bridge placement. On this sense, I would like to talk about the paper by Cardaropoli, Araujo, and Lindy, in which they explain us all the cellular events that will occur after an extraction, and they divide it in 1 day, 3 days, 7 days, 14 days, 50 days, 30 days, 60 days, 90 days, 120 days. So this information will allow us to understand all the events that will occur when we extract a tooth, and how can we work with these events in favor so we can regenerate the bone for the future implant placement. Now, it is very clear that at the beginning we will have an osseous coagulum that will be present for the first 2 weeks. And after these 2 weeks, what will start happen is we will start to see a maturation of this osseous coagulum by the formation of a matrix. And this matrix will be very important because it will start giving the structure over which the osteogenesis will start, and the mineralization process of the new bone formation will start taking place. So when we have the mineralization process complete after 60 days of healing, when the cortical component on the crestal area is complete, mature, then we will have the maturity of the bone to either place an implant or have an implant osseointegrated. So this is what I have in my mind when I have an extraction. And we have seen from the literature, from this paper, that when these areas covered or protected by a gingival barrier, then the healing will go on a better rate and on a faster rate. So this is why I always try to completely cover a regeneration process when I do one. So, with these facts, I like to evaluate the neighboring areas of the tooth or group of teeth where we're going to work prior to the surgery, so I can understand what are the tissues that we have neighboring and what are the real options that we have as alternatives in the treatment to deliver the best treatment for the patient. Now, when we see the drawings of a posterior maxilla or a posterior mandible, we understand that there are certain resorptive patterns that will be more difficult than others to work with. So what I've seen is that the anatomy of the mandible is more difficult, and it is more hard to work with because there are more structures that are on the limit line. It could be a risk for the patient. So I would like to invite you again to this nice trip to take into consideration the sublingual artery, the sublingual salivary gland, the parotid gland, the sublingual nerve. All these structures we must understand very well before we do a surgery. And this is why we ask the patient to take a cone-beam series of images. I think it is very important to have this analysis, and not only on the quantity of bone, but as well on the quality of the bone. So we can see the quality of the tissues and then understand what is the exact component of the patient, the host, and how can we adapt a great implant placement or implant and regenerative therapy so we can obtain the best result. I would like to also mention that independently of the quantity of bone loss and independently of the regenerative technique that we decide to use, everything will be based on the basic science. Basically, we will follow the bioengineering concepts, either autogenous bone graft, PRGF, regeneration, anything we decide to use, we will have our concept based on the basic science. We know there's a cellular component. We know we must respect this cellular component in this certain space or field so we can have the regeneration to its maximum potential. So either we take the autogenous bone graft from the iliac crest or from any other source, we will look for the give the host, the body, the capacity to regenerate, to heal by itself. So give them their space and their time to have a nice osteogenesis and a newly formed bone, and afterwards a good relationship with the implants. So we must understand every aspect of what we're doing so we can deliver it properly. And I think something really important is the order. What is the order and the sequence of steps we will do in order to achieve the results that we want to achieve? Now, with regenerative techniques, I think we understand up to date that the gold standard continues to be the autogenous bone graft. We have seen in the literature, we have seen that when we use artificial bone grafting or xenografts or allografts, they will work well, but not as well as the autogenous bone graft. So then the limit is sometimes where can we take the bone graft from? Sometimes we can go inside the mouth to have this bone graft. Some other times we must go to the cranium or sometimes to the iliac crest. Now, from the different techniques we use to guide bone regeneration, I would like to mention a very special technique that I have been used for some years. So, and this is mainly for when we have a horizontal bone defect, sometimes also vertical, but it's mostly horizontal. And this is a technique in which we like to do a groove in the bone at the apical part of the defect, and in this groove we will accommodate a bone graft as a lamina, as a plate. And these bone graft, autogenous bone graft in a plate form or a lamina form, we will stabilize it with some screws and create a new buccal bone, wall of bone. And from there we will fill in the space in between with some particulate bone in order to have a regeneration. You can see these images of the statistics of the results of these techniques on certain areas and how much millimeters we can gain on regeneration. Now, continuing on the line of the alternatives, the autogenous bone graft will allow us. We will have some cases in which we will be on the limit or on the extreme. And these are cases in which we will have a huge amount of bone to regenerate, but mixed or accompanied by an infective process. When we have this combination, I understand we must take account to control the infective process first and do at the same time a regeneration of the lost tissues. And these are the cases that demand the most out of us. I will show 2 cases today with you. I would like to share these 2 cases with you. And the interesting thing for me here to share with you is the choice of where to bring the autogenous bone graft from. I would like to start by sharing with you the anesthesia technique that I'm going to use, because I think that anesthesia is a very important part of the surgical process. I think that if we don't have the proper anesthesia, we will risk a lot of procedures and we might not be able to perform what we have planned. I've seen through my experience that the anesthesia will allow us to do a lot of procedures if we have a good anesthesia or anesthetic process. So I think that surgery is not something for extremely high IQ persons or extremely intelligent persons like Albert Einstein. I think it is something that anybody can do it, but it has to be a person with a good discipline to understand that we must continue in the surgery and follow the steps and the goals that we have in mind. In our alternatives, we must try to follow them as well. So this case I'm going to show you, we work it with general anesthesia, and it's a patient above 80 years of age. And 8 years ago, she had some zygomatic implants and a pterygoid implant. To have a fixed solution to her dental span on the posterior left side on the maxilla. Patient came referred to me by a good friend in Barcelona, so she had to take a plane to come to see me at Ibiza. She have seen several colleagues before coming to see me, and they all considered that it was too much of a risk to intend to correct her dental span with a fixed option, because she was above 80 and it was too much of a risk. The patient was extremely motivated to look for an alternative to have her on a stable and fixed option, and this is why she insisted in looking for an option that will give her a final result on a fixed area. So what I see is, as you see the panoramic x-ray, she had a fracture implant on the pterygoid area, and then another implant restored on the lateral incisor area. Now I must start by saying that the patient had a medical history of past or previous sinus problems. She had sinusitis for several years, and she had a ENT surgical procedure performed in which they did an endoscopic type of surgery to correct the maxillary sinus. But even though she had this surgery performed, this maxillary sinus was far away from being a healthy maxillary sinus. So you can see here in the video that I'm reflecting a full thickness flap, and you can see there's a communication on the palatal aspect. And then on the buccal aspect, I'm doing a dissection of the flap with going deep with the surgical blade to have a more clean dissection of the flap, having in mind that we will do a new sinus lift, and I want a nice thick tissue to cover these after we do the sinus lift procedure. So the limits of the area will be the bone on the anterior aspect of the previous window to the maxillary sinus. So we go through the same aspect, and we start separating the cnidaria membrane and look for a sinus membrane, sinus lift procedure as we normally do. But what happened and what I encountered is as soon as I separated the cnidaria membrane enough, a huge amount of pus started to come out from the inner part of the maxillary sinus. So in this moment, I want to be very sincere with you. At this moment during the surgical procedure, I was 100% convinced that I should abort the surgical procedure, close back, and forget about the treatment that we had planned with the patient. But the fact that the patient came from a long distance and took a plane to see me, and thinking of all her dental history, of all the mistreatment that she had before, I thought it twice, and I thought maybe I should clean well the sinus and then think about what options can I help her with. I cannot let her go like this. So what I thought is I could try to close first the communication of the maxillary sinus with the sinus, and then try to look for a regeneration process. So what I did is I closed the communication to the sinus first, and then I went to the iliac crest to get an autogenous bone graft. This is the image a month after the surgery, how the incision line on the iliac crest is healing very well. And I am basically following the protocol of Dr. Carl Kahnberg, in which he is working with these type of defects, and he's using iliac crest autogenous bone graft, and he is fixating them with this stainless steel ligatures to have them secure the bone graft and have a good stability for the healing. So when I do these type of grafts, I usually do the same. I do stainless steel ligature combined with fixation screws to have a good result. And look at this picture. This is 16 weeks post-surgery on a patient above 80 years of age. And even though we had the maxillary sinus with pus coming out the day of the surgery, we had the chance to do a complete regeneration of the area. Look at the fixation screws, how they are very well adapted to the newly formed bone, as well as the stainless steel ligature. Now, once we have done this, we take those screws off and we place the implants. And we place the implants with the prosthetic abutment, with the concept of one abutment one time. so minimize the bone loss around the implants. And we can also see an area where we took a biopsy to take a look at the histology of the newly formed bone. Now, since we had a very good stability of the implants, a very solid amount of quality of bone, we decided to do an immediate loading of the bone, and we can see the stability of the implants. So the patient went back to Barcelona and had her on the maintenance therapy. Now the doctor called me, the doctor that is seeing the patient, and he told me that she's ready now to receive the final prosthesis. She had some automobile accidents that have her to prolong the treatment, and this is why she has not received up till today the final prosthesis, but she's about to have her final prosthesis placed in the mouth. Now, if we look at the histology, we will see a live bone and a mature bone. This is what the histologist tells me. So we have a mature bone and a live bone. And this is something very important because we can understand and we can know that after 16 weeks of healing, we will have a mature bone and a live bone surrounding the implants when we use this technique. Now, I would like to show now a second case. Is a patient also on an extreme scenario. And this patient, since she was very young, she had lots of problems with her teeth. She has had so many problems with her teeth for so many years that today when you ask her, how were you when you had your teeth okay? She cannot remember at an age where she could have, where she did have her teeth okay. So I asked her, can you give me a picture when you had your teeth, did you like them? She had to go to a picture when she was 12 years old because she does not have a picture at age 25, 30 or so where she was happy with her teeth. And this is a panoramic x-ray of how she is at this moment. This is how she came to see me at the office, and we can see a couple of communications with the maxillary sinus and the nasal sinus. So we will start by resolving the communication with the nasal cavity first, and then with the maxillary sinus. You can see the pause on the left picture. So we will do a deep cleaning, and then we will see, once we finalize the cleaning, that we have a huge communication of the alveolar process with the maxillary sinus. So we have a maxillary sinus with adhesions with previously pus coming out through this. And when we evaluate the thickness of this buccal bone on the picture on the right, it was very, very thin. It was so thin that with the dental probe, I could perforate this bone. So, of course, I understand that it has no mineral content or almost non-mineral content, this bone. So what we did is we did a closure of the mucosal aspect to have a soft tissue healing and have a possibility to have a closed area of the flap when we do the guided bone regeneration. So when we do the surgery for the guided bone regeneration, I went to the skull to have a autogenous bone graft. So this is the video of how we were drawing the structure of the bone graft we're going to take, and then with the piezo we start drawing the bone grafting areas that we're going to take. And once we take all the bone grafting, we will place some spongeous bone graft and with these we will create a basics for a new regeneration and avoid the the lack of osseous regeneration in this area, so the patient won't have any sequela of the surgeries that we performed. And we were able to have all these bone grafts ready to place at the surgical site. So on the picture on your left, you can see all the bone chips or the bone grafting, cortical bone chips, how we stabilize them with the screws. And on the right side, we can see the panoramic X-ray with all the fixating screws of the bone grafting, all the different bone grafts that we place. It's also interesting for me to see how we have a different level of the osseous bone formation. So we understand that we must level all these osseous differences in the level once they heal. We can see also that on the left side we have an over-eruption previously on the teeth that created that over-eruption of the bone. So we will have to do some osseous resective process before the implant placement on this side once the whole regeneration process finishes its healing process. So in this case, due to the lack of stability and integrity of the bone previous to the bone graft, we will have to stabilize on both sides, on the buccal and on the lingual, so we can have a complete regeneration in a future area where we can place implants. So once we have the regeneration, we'll go ahead and place the implants, and we went ahead and placed 8 implants. And since we had a very strong and solid bone, we decided to do immediate loading. You can see on the image on the right side, we have connected all the implants restored with an immediate loading protocol. You can see the image of the patient on the left side 8 years after the treatment was performed. Patient is really happy, she's smiling, she enjoys her life. And this is the image on the right, is a CBCT image in which we can see the perfect stability of the fixations or the implants. And this is the profile of the patient before the prosthesis and after the prosthesis. And this is a small table in which we go in depth on what we have done with the patient, the management of the soft tissues, how we proceeded, the use of PRGF and PRF, the type of prosthesis, which will be based on titanium and with a zirconium component. And as I resume of what I have lectured today, I think it is very evident that the autogenous bone graft continues to be the gold standard and what everybody wants to get to when we do a regenerative therapy. Now, it is unlikely that existing bone substitutes like allografts, xenografts, or alloplasts will ever challenge the gold standard. However, growth factors may improve their biologic activity and improve the results. Stem cells, signaling molecules, and new scaffolds or areas of intense research in regenerative medicine. So future advancement in tissue reengineering will likely produce alternatives to autogenous bone grafts that may well exceed existing clinical outcomes and replace traditional indications for its use. Until then, we should continue to use well-researched techniques that provide predictable outcomes in various clinical situations. My observations have been that many clinicians have become too quick to abandon traditional well-established approaches for easier, faster, and less complicated procedures that may not provide comparable results. It is frustrating to inherit a case where grafting was attempted using bone substitutes when autogenous bone would have been the preferred choice. I think Dr. Craig Mitch makes a real good point with this closing published on the Journal of Implant Dentistry in the year 2010. I agree 100% with his concepts of the use of autogenous bone grafting. Now, I consider that we will always try to look for new alternatives. It is not that I think that we will use autogenous bone graft forever. I think that there are different roadways, many ways to achieve a good result. We have used many different materials, and we will continue using different materials. I must recognize I use a lot of the different materials that have come out in the market. But when I want regeneration in an important volume, on a limited situations, on a reduced time, I still use autogenous bone graft as my primary mean or my primary usage. I hope this lecture has been good for you, and I hope to see you again on the next video. Thank you for your attention.